So thanks everyone for coming. I'm Savati Shah, I'm one of the cardiologists, and I have the distinct pleasure of introducing Dr. Calum Macrae for DCRI Research Conference. This proves to be a really exciting talk. I'm really looking forward to it. Also to remind you all that Dr. Macrae will be speaking on a different topic at Cardiology Grand Rounds this evening from 5 to 6 p.m. In Duke North 2002. So please try and attend that one because it'll also be very stimulating. So it's really an honor and a privilege to present Dr. Macrae, who I've known for many years. He is our Albert Williams Visiting Genetics Professor. This is our third annual professorship. And thank you to Lynn Williams for his sponsorship of this professorship. So Dr. Macrae trained at University of Edinburgh. He did his bachelor's and his medical school there, received a PhD at University of London, and then did residency and cardiology fellowship at the University of Edinburgh. He then did research fellowships at the Seidman Lab and the Fishman Lab, both at Harvard, and then stayed on in the Harvard system, first at the Massachusetts General Hospital, and then transitioning to the Brigham and Women's Hospital. At the Brigham, he previously served as the training program director, and now Dr. Macrae is the chief of cardiology at the Brigham and Women's Hospital, continues to run a highly productive and very successful developmental and molecular biology lab that uses zebrafish as well as other models to study the genetics of cardiovascular disease. And most recently, Dr. Macrae was awarded the $75 million heart disease moonshot, One Brave Idea project, which was a single grant awarded to one individual who was going to cure atherosclerosis within 5 years. Dr. Macrae manages to, take a pause there, yeah. So Dr. Macrae manages to, triple, quadruple threat doesn't even describe it. He is amazingly facile at everything that he does, speaks a variety of scientific languages at a very high level, and has expertise across a variety of disciplines, as you'll see here. So for those of you who thought you might be hearing a zebrafish talk, stop eating your lunch and really listen to this talk, because it really does speak to how wonderful Dr. Macrae is at a variety of disciplines. Further, he takes time for trainees. I did my residency at the Brigham, and he took time for me even back then. And even in walking down the hall, he wanted to make sure that he understood what he could do for me as an individual. So it's really an honor to present Dr. Macrae, who will be speaking about connecting care and discovery, a real-world learning system. Thanks, Calum.
Svati, thank you very much indeed for that overly generous introduction. I have to tell you, I did not think, maybe even 2 years ago, that I would ever be talking to DCRI. And what I'm going to tell you about is really something that we've been trying to do across the Brigham that I think is relevant to what's going on at DCRI, relevant potentially to much broader areas of interest, and things that really I've been stimulated to learn about and to think about by Rob Califf, who's in the audience. And if there's one thing that I have to say that has come out of One Brave Idea that early on, that may not be a cure for coronary disease, but it's certainly cured my sense of what it's going to take to move the field forward, is getting the chance to work with Rob, who's now on the oversight committee for the One Brave Idea. These are the sort of frameworks of what I think we all believe we should be trying to do. So it's this concept of the learning health system, where data seamlessly gets uploaded into something that looks like the matrix. There's a complex set of analytics deployed, and then suddenly an output comes out the other end that cures the disease, or at least has a major effect on that individual's long-term outcome. The fundamental problem with this is that it doesn't exist, and there are a number of reasons I think that it doesn't exist. And what I'm going to try and do in the next 30 minutes is highlight what I think are the core reasons that it hasn't really emerged, even although I think people were talking about this when I was first a resident in 1987. But also try and identify the ways that I believe what will come out of this, what will drive this, not only a result of external pressures, but also a result of us getting back to the core mission in medicine, which is driving care to individual patients. We did a sort of word map a couple of months ago, actually this was something I did for Partners Connected Health, thinking what is it that we believe is, as a collective group, this is a group now of about 70 people, is missing from the concept of the learning health system. This is a group at Partners that is working on exactly this topic. And one of the interesting things, and I did not in any way curate this, and I was kind of surprised that people really felt like this, but the two dominant things that came out of our group were missing biology. We're not actually focused on what's going on in real patients. And then perhaps the most obvious two things that are in the middle and at the bottom, that's information content, that most of the data we collect is actually really largely redundant. And then finally, trajectories, that we collect cross-sectional data and we don't really have any meaningful understanding of the dynamics of data over time in individual patients or individual healthy subjects. Digital technologies in medicine are at I think a nascent stage. We just spent $2 billion implementing Epic. I know you guys have had it for longer than we. EHR penetration in superficial terms is almost complete. But if you actually look at the top of this graph, the stage 7, those individuals, those networks, those systems that are using the EHR really for robust decision support, it turns out it's less than 5%. And I would argue this also is an overestimate. Most EHRs have very limited functionality. They're largely focused on transactions or episodes of care. They're not based on any meaningful biological transactions. Remote activities are restricted. There's a whole host of patients that we have coming asking us if we will add their genome to the record, that we will somehow add their continuous monitoring of their blood pressure, their heart rate to the record, and we just simply don't have the facility to do that. But I think part of the reason that the EHR and digital technologies in general have failed in the healthcare system, and I don't think the US is any different than most other countries, is that the way that we think about digitization is actually, I think, fundamentally flawed. Professional scope has barely changed. There's been no change in the way in which services or even the end user experience has changed with digitization. And most EHR implementations really have only driven up cost. At the core of this is the absence of any real changes in workflow, very protracted innovation cycles. It took us almost 3 years to get Epic implemented across the platform, by which time all we had really done was instantiate workflow from 5 years earlier. And then the fundamental problem is that it hasn't really added any expert systems. There isn't any emergent property in any of the platforms that we use. And if you compare this with other fields, it's actually quite disturbing from two standpoints. One, we paid a lot of money for something that doesn't deliver anything really meaningful. And two, this is what we're actually going to end up with when other systems outside traditional medicine, or hopefully ourselves, when we begin to try and pull together in a meaningful way an internal system. This is the impact. These are the changes that will happen to our current models. Most systems, most industrial areas of endeavor had almost complete penetration of digital technology about 10 years ago. If you show Epic to somebody from any large retail chain, they will say it's roughly where their supply chain management was in 1986. With all due respect to Epic, I think we designed it ourselves in many ways. And largely the thing that we didn't do was build the digitization around the primary demands of the consumers. We built it around the primary demands of the payers. So almost everything in healthcare is billing based. What you'll see, and this happened obviously almost overnight with travel agents, it took a little bit longer with bank tellers, but if we did, and I believe this is one of the reasons that we haven't actually implemented real digitization in healthcare, is that we actually have actively resisted it because it will result in significant reduction in the numbers of professionals. Perish the thought, it will add volume and quality. It will improve efficiency, and ultimately it commoditizes what we're doing. And that's something that because we actually as professionals control this, have resisted actively in almost every instance. One of the most interesting things is to see just how dramatic has been the change in jobs in healthcare. We implemented EPIC in an effort to reduce the maintenance of our legacy systems, and what we ended up doing was actually increasing the cost of maintenance of our new legacy system. And simply because of the fact that we haven't thought about how we can use this to disrupt care or to disrupt what we already do, I believe we've completely missed the boat. This is just a summary of what I just said. Why has medicine fallen so far behind? The data we collect, how we collect it. Analytics are limited by the fact that most of the data sets cannot be integrated at any scale. Almost everything is a series of small networks of about 6 to 10 million patients. There are very few real large data sets. We don't even understand how to display the data that we collect. Implementation science in general has been constrained by the randomized control trial. There's nothing, obviously, talking at DCRI about randomized control trials and is itself risky. But what I think we've done is by creating infrastructure that is a separate universe for the RCT, what we've done is remove the clinical trial platform from the patients who actually need it the most. Actually, one of the most interesting things in this space is if you look at cancer, most cancer centers now, about 87-88% of patients in a cancer center will be in a phase 2 or a phase 3 trial. In most chronic disease states in cardiology, it's closer 3 to 5%. So that immediately tells you how advances in the way that you think about care can actually drive dramatically the penetration of translational science. As I said, we've designed almost everything around episodes rather than trajectories. Almost everything is digitizing 18th century workflows. The whole concept of ward round, the whole concept of notes, history, and physical is itself, I think, completely distorted. We use cut and paste rather than relying on objective data that are already in place. And then I think perhaps the most obvious things that are a problem are the financial isolation, the lack of competition, and the professional resistance that I alluded to. What did I learn from co-chairing the research integration of EPIC across the entire partners network? I learned two things. One, manual entry of subjective data is not the way forward. Simply digitizing existing workflows or data sets is low yield. We've invested far too much in the acquisition of data that we're not really interested in. I always say, I don't even care what I thought last week if you need natural language processing to extract it. And with all due respect to you, I work in natural language processing myself, so I'm just saying that at the end of the day, most of what's in the EHR, there are 13 or 14 objective variables with no metadata, and the rest of it is essentially semi-subjective reporting of purely subjective information. So we need to think about new ways to get information into the system. We need to invest in the delivery arm because that's ultimately what drives innovation in almost every part of medicine. And then ultimately, we've had very, very few successes with real changes in workflow. But where we have had them, they've been quite obvious. And I think where predictive decision support has really had an impact is in areas like radiology, where you can actually standardize objective data after the first round of thinking about it. And so with this context, what I thought I would do, actually I'll skip this slide because I've said it already, is really think about the input and output limbs as part of a redesign exercise. So if you were going to build a system to do what we all wanted to do, which is to be truly learning, how would you go about doing that? So I think the core element in all of this, as I mentioned at the start, is the lack of information content. And the problem is literally that we've just collected the same information that we always collected. Most of what we think about is our data that were really set in place probably 200 years ago, limited physical exam data set, reported again semi-subjectively, not thought through in terms of the mechanics of how we would systematically expand it to find non-redundant information. And so it's not surprising that whether it's in genetics, so this is a standard, I realize there's no point in pointing on a screen, standard genetics, most of the work has been done in large effect size, Mendelian diseases, or small effect size common alleles, but the real bulk is going to be in here. It's things that only really become apparent when you live beyond the age of 30, which is, as a society, we've only really started to do in the last 50 to 100 years, so there's been no evolution in that space. Or there are things that we don't measure, characteristics that we don't fully understand. And I will argue in a minute or two that most of what we measure in biology is really an extreme end of one spectrum. And then the second thing that we don't do is understand the conditioning variables. We measure essentially only two conditioning variables, alcohol and tobacco. Almost nothing else is systematically entrained. Clinical trials have suffered from this lack of stratification, and then care design is also suffering from it. I was telling people this morning that we recently did a post-hoc analysis of a digital trial of looking at heart failure readmissions, and the only signal really that dictated in any meaningful way what was happening in terms of readmissions was chatter, social network or telephone chatter, or even television chatter. What you're doing, the basic mechanics of your daily life, actually end up being much more informative than even a PA monitor in terms of your risk of readmission. Obviously, that doesn't diagnose heart failure in any meaningful way. But if you already have heart failure, it's a predictor of incipient events. This is the sort of scale of the gap. So if you add everything that we measure in clinical medicine, it comes to about 9,800 things. And so it's not surprising that we don't have enough information to deconvolute a genome. Everybody in the room differs by about 10 to the 6, maybe 2 times 10 to the 6 variants. So there's not enough information. If we collected everything that we've ever collected on every patient, we still wouldn't have enough information to understand the difference between any two people in the room. And we're off by 5 to 7 orders of magnitude. That's before you even start to think about transcription, proteomics, the way in which cells are put together, all of the differences that make us who we are. And before you start to think about all the different timescales. In addition to that, if you think about how we conceive of disease, it's always expectant. We're waiting for people to come to us out here with an event. And then we follow them using, as I said, the same data sets that we've always used. And the main thing that drives what we measure is actually evolving treatment options. And that's an important lesson, I think, to think about is, why is it that that's so important? Well, it's largely because there's a regulatory infrastructure around that. There's actually some system in place. There's almost no system in all of the rest of medicine. When we start to think about cardiology in particular, we have actually made some efforts to move back into prevention. But this large area of white space, this is where every other industry on the planet is focused. This is where our patients are focused. Why can you not work out when I'm starting to get unwell? Why do I have to wait to tell you? Because in every other part of their lives, it turns out they're actually able to get information like this. They're able to get it in real time, and they're able to get it for a relatively modest cost. And we just as a system have in fact focused on the terminal parts, the things that we could do 50 years ago. We haven't really built any approaches that will allow us to think about how to change it. One of the things that you can begin to do is to standardize existing data. I always say there are only, and this is a challenge if anybody can think of anything before the end of the talk, there are only 2 standardized metrics in all of human biology: the 12-lead electrocardiogram and the international normalized ratio, even if only because it has international and normalized in the title. But literally, I don't think there's any other single phenotype in all of biomedicine that's standardized. If you look at, we did machine learning exercise about 3 years ago with imaging at the Brigham. We were able to identify the technician who did the scan. We were able to identify the scanner. We were able to identify the physician who supervised the protocol. We were not able to really meaningfully identify any other information that was not already encoded in the report. And I think that just tells you a little bit about how we have failed as a data collection architecture in modern biomedicine. If you look at the 12-lead electrocardiogram, the patterns on the 12-lead EKG and the long QT syndrome are known to actually determine your risk of sudden death, the stimuli that will actually cause sudden death. Those EKGs were available for 95 years before anybody picked up this pattern. And the only way it was picked up was because people cloned the underlying genes. Metabolomics, I think, obviously, there's some world experts in the audience. Metabolomics, I think, a fabulously rich data set. But again, in the absence of flux, in the absence of dynamic challenges, in the absence of standardization, remarkably high coefficient of variance, remarkably little in the way of longitudinal responses. And I think even looking at metabolomics as an example, you realize that if you have a stimulus, if you have a meal, if you have a metabolic challenge, it turns out already you start to see reduced coefficients of variance. You start to see much, much better data sets. And ultimately, what we need to do is think about how we build more generalizable, computable phenotypes with the right infrastructure to collect those, and ultimately the right infrastructure to analyze those. This is one great example is diabetes. So we've known probably for 15 years that there are branched-chain amino acid abnormalities that antedate any abnormality of insulin resistance, any abnormality of plasma glucose, any abnormality of urinary glucose by about a decade. But we have failed to be able to implement that because our entire diabetes management is based around glucose, which turns out to be a side effect of hypoglycemia is a side effect of insulin. It's not really the core underlying biology of diabetes. The core underlying biology is actually abnormalities of metabolism that antedate, as I said, sugar abnormalities by a long shot. We record data in ways that are, as I said, are semi-subjective. We measure things that are literally medieval. I mean, tasting the sugar in the urine was literally identified in the Middle Ages. We haven't thought about how we begin to build in all these other metrics, and these are just the ones that we know about, that are actually really good markers very, very early on of what fundamentally is the problem in diabetes, which is pH regulation. That's what people die from, is abnormalities of cellular pH. They don't die from too much sugar, which is one of the reasons why if you treat sugar, you don't actually end up with dramatically improved outcomes. You're not actually treating the core elements of the disorder. All of these things are available. We've known how to measure, for example, capillary abnormalities in diabetes for many, many years. They're now bedside single fiber confocals that you can pop under a fingernail, understand capillary fragility, capillary patterning, capillary permeability. We just never do that. We don't map thermography. We don't think about the distribution of your lipid, subcutaneous or visceral lipid as a means of identifying that, which type of diabetes you have. And then finally at the bottom, the 12-lead electrocardiogram turns out to be quite a good metric of a subset of diabetics because it actually is a marker for a very discrete pathway of insulin resistance, but you never see people managing diabetics on the basis of their electrocardiogram. And then I think perhaps one of the most interesting exercises we did, we were trying to think of orthogonal variables that actually help you classify diabetes. So here's one that I think is actually quite interesting. If you look at the distribution of glucose in diabetics, it's Gaussianly distributed around a mean of about 137. There's almost nothing that stratifies that that's in the traditional clinical record. If you add one variable, shoe size, you can pull out 5 of the 12 Mendelian forms of diabetes because they're dwarfisms or gigantisms. And again, when was the last time you even saw shoe size in the electronic record? Never recorded. But there is actually an internationalized standard, or at least an international framework for standardization. What we've begun to do as part of One Brave Idea is build these multidimensional digital physical profiles. And this came out of work that we started actually in our heart failure program about 5 years ago. We began to look for data sets that were already in the record, that were stable and very reproducible. So we looked at auditory evoked response was one of the first ones. It turns out that if you look at LVH, if you have any abnormalities of LV wall thickness and you have an abnormal auditory evoked response, it parses out almost perfectly. If you know, in particular, if you know their peripheral galvanic skin resistance or any nerve responses, you can pull out the senile amyloids at the front desk while they're checking in. Similarly, stride length, we worked with Xerox a couple years ago with a near-infrared camera in front of our Echo Lab. So as people get up and go and walk into the Echo Lab, you're able to actually identify stride length, whether they have limb girdle abnormalities, whether they have any other skeletal muscle abnormalities. And interestingly, you can see here, this is data from about 400 heart failure subjects with reduced ejection fraction. See remarkable parsing of the differences between ischemic and non-ischemic heart failure, just based on stride length. We've also done some work looking at skin biology. It turns out you can actually identify stable phenotypes in skin that are actually very, very reproducible over decades that predict atrial fibrillation. They predict the risk of right ventricular outflow tract tachycardia, again, albeit in very narrow pretest probabilities. So we're now beginning to scale those to much larger populations to see if we actually have the predictive utility that we'd like. As far as curing coronary disease, I want you to realize I did not promise to do that. Don't hold me responsible. I said, and if you watch, I always say moving toward curing coronary disease, but I've had to fight the marketing gurus quite hard. But these are some of the phenotypes that you might imagine collecting just off the bat. We know these are all abnormal already, but we never really systematically collect them. So if you look at, for example, at retina, there are now iPhone apps that will take very good photographs of your own retina without really almost any additional devices. You see macrophage accumulation under the skin in xanthelasma or xanthoma. We have now started measuring using a nanoneedle that aspirates macrophages from the wrist. You can actually study lipid turnover in about 10,000 macrophages a day. And then vasomotor responses and drug responses turn out to be very predictive of risk of coronary disease or atherosclerosis. This was work done with invasive tonometry in the mid-'80s and the mid-'90s. Largely by a guy called John Deanfield in London. And now with wearable tonometers that are accessible through either Verily or Microsoft, we're beginning to look at whether dynamic responses in teenagers predict the risk of vascular disease down the line. And drug responses I'm going to come back to in a minute, because I think if you're thinking about what it is that allows you to organize complex data sets, drugs turn out to be an incredibly powerful tool. And so I believe, and I'm going to make that argument in the next few minutes, that the way to really drive all of this is actually to think about what the perturbations are. And if we're not using the implementation of current therapeutics or clinical trials as means of identifying new biology, then we've completely missed the boat. And this really speaks to this at the end. We're building this platform to try and identify what we call next generation phenotypes. At the end of the day, what they really are is new digital metrics that are linear, that are quantitative, that are readily accessible, that can be collected in an ambient fashion, funneled straight into the record, have universal standards, and are potentially scalable. And in fact, scalability ends up being one of the most important pieces of this. In addition to that, we also think we have to identify perturbations that are meaningful and discriminate between the different forms. So for example, for coronary disease, one of the things we're doing is looking at different nutritional challenges in kids. Fructose, sucrose, maybe even a microdose of a statin would actually be worthwhile. And we believe that ultimately what we need to do is redesign the clinical environments, both domestic and the clinic, to begin to actually add this type of information, collecting in an agnostic fashion things that reclassify disease in a meaningful way. And as I said, I think there are only two types of metadata that allow you to really study things at every level, from a single cell or a single molecule all the way up to a population. I used to say an organism, but Rob has convinced me it has to be population. And that's small molecules or biophysical stimuli. And in fact, as part of One Brave Idea, one of the things that we've started to do is work with a car company, because it turns out if you actually look at where biophysical stimuli are recorded most faithfully in the general environment, it's actually in cars. All of the accelerometers and decelerometers in a car that are actually designed to trigger both your safety responses, but also things like ABS and the airbags are really probably the most sensitive, universally deployed sensors on the planet at the moment. And so the goal would be to redefine disease by building these computable phenotypes. You have a whole host of new data sources that ideally you're picking to fill out the space that we don't currently interrogate, and to do it in a scalable fashion. If we do that, we hopefully will end up with real-time stratification. You get continuous audit, which everybody likes because it helps you begin to understand your system. And then you can optimize both for cost and risk, for virtual versus physical visits, for a whole host of other things. And it was thinking about this that made me realize that ultimately this is actually the care network that you need to create. That the quickest way of doing this is not to invent the devices, because that will take time. It's to actually build a system that delivers current care more effectively. Because you're going to need that no matter what the devices are, no matter what the biology is that you measure at the end of the day. If your standard of care is not standard, then you have no meaningful information. These are data from diabetes care a couple of years ago, showing that basically fewer than 20% of people who have diabetes have all of their preventative metrics at goal. And that's in a fully insured population in North America. So you can imagine what it's like across the country or across the world. And when we started to think about this, you realize this care delivery matrix has really not changed very much in the last couple of 100 years. So you have a specialist physician or a whole team of professionals working with individual patients. And what you really need to start to think about as care complexity drops, or as your ability to manage more complex care changes, is to change the scope of what we do, the access to what we do, and the cost of what we do by driving this towards population-level biology, population-level care. And in fact, the only thing that really at the end of the day dictates whereabouts in this spectrum that arrow sits is what the data capture is like. So if you're collecting good enough data to modify the system in real time, you can actually have patients looking after the entire population themselves. There's absolutely no reason you need any of us to actually be doing most of the things that we consider as evidence-based or evidence-driven. I looked at this in the partners system. I did this across the whole of partners, but I'm going to show you the Brigham data so that I don't get into any trouble. Traditional care relationship, 50% of traditional face-to-face visits are difficult to justify. At least 40% are essentially unbillable. That if you look at it, the things that change are simply not things that you can actually bill for in a secondary or tertiary care setting. When we started to analyze this, we thought, what is it that providers, and I use this widely, bring? Well, they bring cost. They have fixed salaries. They bring variation, or at least they do in the partner system. They bring variation, huge variation. They bring arcane workflow practices. I like to think of what most people think they're delivering as standard of care is really sort of artisanal care. They're modeling things around their own individual preferences. They bring timing constraints. They bring scaling constraints. They have lots of benefits. They bring pattern recognition. They bring biologic and pharmacologic insight. And we also believe they bring the human connection. Although I'll show you in a minute that actually the human connection is remarkably independent of any need for 15 or 20 years of professional training. And what I think they bring is actually investigative function. And that ultimately is what used to be the case for all professions. Professions were defined largely as the ability to manage ambiguity. And if there's no ambiguity, which I hope you would agree has occurred as a result of some of the remarkable successes in clinical trials, some of the remarkable successes in building evidence structure, then you should be able to push all of that outside the traditional medical environment. And so that's what we began to think about doing. And obviously, we're not the first group of people to think about doing this. People have talked about having apps. There are even some of the people we work with at Verily have already built apps for managing diabetes. But the interesting thing about those is they're still quite provider-centric. They're still based on the model that somebody who has professional training is going to be looking at the data and running it. So we thought if you are going to build a truly standalone app, what are the rate-limiting steps? What are the things that would allow a patient to manage their own heart failure, to manage their own diabetes, far less their own lipids or inflammation or their blood pressure? Things that we should probably have let go in the medical profession or in the healthcare profession probably about at least a decade ago. And the real problem is this: digital adoption in actual patients is remarkably low. If you look in the bottom left-hand corner, the willingness of people to even use the phone for healthcare is only about 60% in the individuals over the age of 65 in Massachusetts. If you look at app-based care or video care or any of these other technologies that are remote, it's about 20%, and it's not growing very fast. So what we decided we would do is actually just to eliminate the providers directly. That immediately drops cost. And to use, we've actually hired some really remarkable college graduates. We're now actually, for some of our programs, hiring high school graduates to manage some of these illnesses. What we've done is built platforms, software platforms that run behind the firewall. So you don't need the patient to be able to use them. What you end up doing is using the information from the transactions of care in a way that actually drives all of this. And these health navigators manage somewhere around 1,500 patients each. So they're about the same size as a significant, but probably not super large, primary care physician. The implementation of the algorithm is supervised by pharmacists, by RNs, by MDs, but we've actually found that we don't need the RNs and MDs. The average number of times in any of the programs that I'm going to show you that an RN or an MD is involved is less than 1 in 1,000 cases. So if you think about that, you start to realize that we may not be quite as vital as we think we are. The other thing that's nice about these platforms is you can drive care through them, but you can also drive education. And importantly, if you build the right data return cycle, I believe you can build a really sophisticated research platform. And that's what we've begun to think about building. The best thing about it is you can change the workflow. We deliberately had the workflow developed by the navigators and a software team without any provider involvement at all. No MD, no nursing involvement. We just let literally the software engineers and the navigators drive the workflow. What we get is uniform implementation. De facto, everybody gets to the same endpoints, and you measure those endpoints. You have a remarkably importantly, you have software training before any patient is using the software themselves. So this allows you to overcome the problems with minimally viable products in healthcare delivery. And then ultimately, if we define the right data return cycles, we end up with, I think, the ability to do everything from clinical trials in the record to basic science, and we're in the process of negotiating our very first pivotal phase 3 randomized controlled trial. I do think this is going to require scale that goes beyond a single network, and I'm hopeful that we'd be able to do this type of thing in conjunction with groups like yours. We've deliberately set up all the software so it's open source, and many of the things we're doing are actually, we're partnering. For example, our heart failure program, we're partnering with Adrian Hernandez, who's actually doing a parallel effort with a different model here locally at Duke. What we've done is build these disease management programs in multiple states. Lipids and inflammation are about 50,000 patients. Hypertension is going to be at 50,000 this coming spring. Heart failure is in the 1,500 patient range. Diabetes, anticoagulation, and atrial fibrillation are still all in pilot phases, so in the 1,000 to 1,500 patient range. And what we've basically said is if you have the right AI at the front end, if you have the right algorithms in the middle, if you have the right execution platform, and you have a learning cycle, you can begin to do this in a way that's totally platform agnostic. So everything we've done here is built with Smart on Fire in an effort to try and drive this so that it's EHR platform agnostic and can be moved directly to the patients. In fact, the other thing that we've done is built all the software platforms are actually accessible. The same platform is accessible to the patient and to the advanced practitioner, and all you do is drill down to different levels in each of them. So everybody's sharing the same information and has access to it and can control it. These are some of the initial results with the first. We now moved on from our lipid program, but this was the first 767 patients. So on average, a 40% LDL reduction and a 60% cost reduction. Importantly, the patients, 77% of patients actually had increased satisfaction compared with their primary care. This was one of the things that worried us. So I think the human connection, it turns out when you interview these people, they actually prefer the human connection with a human they can get in touch with, rather than a human that says he's going to see them or she's going to see them in 3 months' time. And this actually was, for us, the biggest concern, is the elements that we, as a profession, for decades have said we can't give up because that's part of the healing process, were actually are the pieces we're failing to deliver most regularly. The other thing that tells you a little bit about what the problem is at the bottom right-hand panel is the response rate from 400 physicians in our primary care network. Only 22 of them got back to us with any form of response. And whereas we had 767 responders out of our 1,000 patient survey. So I think one of the things that tells you is the provider system is actually completely overburdened, and part of the reason they're overburdened is they're doing stuff that is not in any way meaningful or professional. We've done the same thing with blood pressure, about a 21, 22 millimeter reduction in systolic and about a 10 to 12 millimeter reduction in diastolic blood pressure, which again turns out to be better than most of the large randomized controlled clinical trials. What we think we need to be doing is redefining the way that we think about disease and delivery, and that redefines the ecosystem. We're doing this in parallel, obviously, with Verily, but also thinking through how we do it with a whole host of other partners. Payers, I talked about with the lipid management program, we took on a large number of patients for a very reasonable amount of money from their standpoint. We're able to deliver much better care. We took, for example, one of our projects, we took 400 people who were labeled as statin intolerant. We got 92.5% of them at goal on statins within 5 weeks, with not a single physician involved in any of the management. PBMs, pharma and biotech, obvious alignment in lots of different ways. Interestingly, the tech industry is also aligned, but in ways that are, I think, still evolving. They're not quite sure how to move into this space, but they do know they need to get into this space eventually. Retail, as I mentioned, is probably a decade ahead of us in thinking about this, but they're converging on a preventative strategy in the long run and thinking about subscription models for healthcare, which I think will be completely disruptive. There are a couple of very large retail chains that are thinking about global provision of all preventative healthcare in the range of about $100 a year. And then finally, federal involvement. We had a really interesting set of interactions with CMS in our heart failure program, based largely on the fact that they're interested in thinking about how you attribute value to interventions. So they want to be able to identify who actually is getting any benefit from the interventions when they're being delivered. Ultimately, I think, and again, I'm really just postulating this, but I do believe it is the way forward, that if we think about what the foundation is of this true learning healthcare network, it's actually delivering existing care right now. That's how we fund it, that's how we build the foundation. And then if we layer in both fundamental research, but also new data streams to help us manage that cycle of learning, then we end up in a position where all of these components that we're all actively involved in are part of the same system. So that human research, animal model research, subsequent drug discovery and translation, clinical trials, and clinical care delivery are all part of the same single system. So in summary, I think information content is the rate limiting step. We need systematic approaches to collecting the right information content. Why would we not do that in a way where we're building a system that works for something that people need right now? And then finally reinventing all of this allows us to integrate care and discovery in a really meaningful way that turns the system into a truly learning health record. These are the folks at Partners that have been working with us, both at the high end of the clinical care spectrum, people way above my pay grade, our research computing, our analytics group that recently got a very big grant from GE and from NVIDIA, Joe Kvedar, who's built a lot of device integration, and then my cardiovascular innovation team that includes some trialists that you probably know, and then the OBI team, including the Joint Leadership Group, which involves both Rob Califf and Bob Harrington. So you can see that I'm heavily influenced by them, and I do believe that ultimately the solutions are global and integrated and not local and parochial. So thank you for your attention. Happy to take questions.
Cal, that was sort of breathtaking spectrum. I guess maybe the main thing for this audience might be a further discussion about, let's say that one accepts the vision that you have that practically implementing things that improve health, for the most part, need to overcome obstacles that are created by the healthcare delivery system. What pace do you actually see this happening? And if, to the extent you can do it, what are the obstacles that you're encountering? But what does it feel like when you're trying to change this?
So you get a lot of local scale. What resistance is probably the most obvious thing. I will tell you that one of the reasons I did this and began to do it 2.5 years ago was coming into a system where I have 4 clinical trials groups that report up through the central division infrastructure. And the horizon for each of them was, I think, pretty similar probably to the horizon that you have here at DCRI, which is you've spent a long time working on large phase 3 clinical trials. And what's happening is people can no longer afford to do those. And so you're starting to see an environment where the cost expectation of a clinical trial is going to be tenfold less. The scale of people that you need to train in order to keep the cost low and to avoid the necessity to build up infrastructure and wind it down with every clinical trial is enormous. You need to, if you want to study 10,000 people with acute coronary syndrome, you need a huge network of people who are ready and trained in order to be able to do that. And so I began to think, how can we start to do something that will I can actually show to the clinicians right now is improving their panel size, reducing how much time they spend on, essentially relatively poorly reimbursed or not reimbursed at all clinical activity, at the same time as building something that could be the core of a platform for real-world clinical trials. So the areas of resistance came from exactly where you would expect. They came from the clinicians who saw this as taking away the easy part of their work. So I had people saying, if you're looking after diuretic, ACE inhibitor, ARNI, and mineralocorticoid dose, what am I going to do as a clinician? And I said, well, you're going to look after the people who are sick and actually need real interventions. Same thing with primary care. At first, primary care, where if you take this away from us, we're gonna end up with many open appointments. What they ended up doing, in fact, in partnership with the leadership at Partners, we realized that we could actually use this only in conjunction with a reward for changing panel size. So it allows the average PCP to increase their new patient panel by about 150 if you implement this at scale. At least in our system it did. The other resistance came from the trialists. The trialists were initially, there's no way this is going to ever be accurate enough to do a clinical trial. And I completely agree. I'm not, you show this to Mark Sabatin and he's laughing at you for at least the first couple of times you present it. But in the long run, if you actually think about it, what are the objective data you really need to collect? You need to collect data on compliance. You need to collect data on outcomes. And you need to collect data on whether, on all the intermediate data sets you need for safety. And I think you can actually, with the right, if you think about the One Brave idea, if you think about what Google, Verily, every other tech company on the planet is thinking about, that will converge rapidly on the level of resolution that you need to do a rigorous clinical trial in a record like this. And for example, if you're looking at short-term goals like end goals of lipid or blood pressure therapy, if you're looking at short-term goals in terms of readmission rates or secondary event rates, those can readily be done with the existing EHR. It's only when you start to have to think about primary safety studies that you end up really needing the architecture that I think will take a couple of years to emerge. But even in the last 6 weeks, those RFID pill surveillance strategies, I mean, that would give you compliance information that's an order of magnitude better than most RCTs that have ever been done. You're watching every pill and its timing, so you have date and time-stamped physiology downstream of it. There's a whole host of ways that you can imagine this being better than the traditional RCT if we design it that way. And I think that's really all I'm saying is if we're going to design a platform, the reason I picked this one is because it's so mundane that you can't imagine not wanting to do it. And yet if you do it properly, it ends up being the basis for a definitive learning health system.
What is the reimbursement mix and Partners right now in terms of fee-for-service versus other arrangements?
ACO. So we're about 40% ACO. Most of the rest is either commercial fee-for-service or Medicare, Medicaid. So we've done this. It turns out the most difficult place to do this is actually in fee-for-service because there's not really a clear fee that covers this. For ACO, we use chronic care. I mean, this costs, to do all of preventative cardiovascular medicine costs about $300 a year. And so you can pull that in the chronic care payment pretty easily. And so then the real question is, how do you pay for scaling? Because you need cash flow to do that. But again, that's the sort of thing that I think with aggregating, let's say you were to take your system and our system and go to a national payer and start to think about doing that, that's something that makes obvious sense because then they've built a platform that can start to do trials in ways that no other platform could do.
Dr. Pearson?
So Calum, that was incredible. And it's fascinating to me to hear you giving these lectures. In part, it's like every other person, when you come to a field sort of distant from your own everyday research, you come in with new ideas, and that's pretty phenomenal. And perhaps a new enthusiasm that you can make it different this time.
I have no illusions. I have no illusions. Don't worry.
So we have systems very well that can document clearly that we're deficient. Where, if you look at any of the metrics, hypertension control, lipid control, diabetes treatment, we might be slightly better than average in the country, but certainly have in our series of issues. I'm trying to determine, and I know we have the exact tools you do, so that doesn't differ, but I'm trying to determine at what stage are you? Is this in routine clinical practice, or is this still in pilot study?
So for two of the programs, it's in routine clinical practice at the Brigham, and it's going to go to Partners in the spring. For the others, it's still for heart failure, it's in development. It's about several hundred patients in for AF, anticoagulation, diabetes, obesity. It's sort of in the early pilot stages, so hundreds of patients, not
But the two that you
thousands of
said
patients.
are in routine or prevention?
Lipids and blood pressure. And so they're...
And both the hospital health system and the doctors have bought into letting their blood pressures be managed by some system other than their
Not
themselves?
uniformly, but 85, so for example, for lipids, 85% of patients identified as at risk are in this program in the Brigham system. And it's going to be, I mean, we have to finalize the exact funding mechanisms, but the goal is to scale it to all of partners, which is 6.6 million covered lives if you include the whole network in the spring.
You should talk to our vice chancellor.
But you're right. I mean, the problem is actually doing this in a way that makes logistic sense in the short term. And I will tell you, it is remarkably difficult to overcome some of the core problems. No, you know what I tell you is the problem is that people feel really as if it's part of what they do, and I actually do believe, I believe for myself for a long time, that the enactment of routine care is how you learn about people for the future. But unfortunately, when we looked at the data, which I think is what you're referring to, it's actually incredible how poorly treated people are. So I can tell you, so this is public knowledge, I'm not breaching any confidence, 20% of people who have Blue Cross Blue Shield insurance, top-of-the-line insurance in eastern Massachusetts who belong to a partner's primary care physician have never had a statin prescription written for them in the 2 years after their infarct or their stroke. So they got it in the hospital, never got it again. It's 40% for Blue Cross in Kansas. Heart failure. If you're not in our advanced heart failure clinic, your chances of being on more than 3 of the 5 indicated drugs in the guidelines for heart failure are less than 22%. And your chances of being on the optimal dose of any of the drugs are less than 20%. And then you think about the implementation cycle. So what's the average time? Well, I know it's true. Well, but it turns out, I hope those are reasonably universal figures. We were deeply disappointed, and then we saw that they're actually pretty much par for the course. I mean, that's the other thing that coming into a field from the outside is you reinvent. I mean, I did stuff internally that I could have just read the literature to find out. But then the other thing to think about is, so I heard a really interesting fact a couple of weeks ago. So in the first 48 hours after the OS 11 operating system on the iPhone was released, 900 million people upgraded it globally. How long does it take healthcare to upgrade? 12 to 15 years after it reaches the guidelines. So that's the type of problem that we have to be able to overcome. And the reason that I think
that's the FDA's fault.
It's true. But that I do think is that's the stimulus. I mean, Rob and I were talking with Fadi on the way over. I think that's, what is it that will drive the change that we need? It's stuff like that. It's basically saying that getting the things that we know to work, that we know work to work, is the driver for allowing us to build the platform that we need as a community to actually build a learning health system. And I do think that will ultimately end up being a relatively small number of nodes in a global network. I'm convinced that the people who are already in this space are the people best equipped to drive this forward. And that's one of the reasons it was an honor and a pleasure to come and talk to you guys, even although I obviously know nothing about clinical trials.
So, Calum, I thought that was a fantastic talk, great overview, innovative, concrete example, which it sounds like you've done a great job balancing the patient and the provider components. On the molecular data side, to switch tracks a little bit, I think of the CYP2C9 example. Can you comment a little bit about the burden, the level of evidence that's necessary as we think about these single molecular data points, but even decision support and decision algorithms with bigger molecular data? What level of evidence, how do we balance all that as we think about implementation science and bringing this to the clinic?
So again, I think those, if you think about those as problems that we've encountered before. So the thing I always use when people ask me this question is troponin. So troponin started off as a stratifier in acute coronary syndromes. And now it's essentially something everybody needs to get measured every day. I mean, that's how the transition seems to have occurred. People, if you come into our emergency room, no matter what you come in with, the chances of you getting out of there without your troponin being measured are almost zero. And then everybody will interpret it as the only test that has 100% sensitivity and 100% specificity, which is itself unique. The way it ended up, there were no randomized controlled trials of measuring troponin in routine emergency room patients or in folks walking through outpatient clinics. Implementation actually drove, I think, because current implementation is not very well structured, drove almost global use of a technology that has very little in the way of evidence to support it. And I think we use that shibboleth that we have to have everything tested in an RCT in order to actually be able to truly understand how to use it. And I believe that actually systems like this are much more efficient ways of understanding how to use this type of information. You start off in a situation where you understand at least why you're beginning to implement it. You need to know something about it. But then you do A/B testing in a system like this, and you have answers to questions that we never even ask in the current system. So I think ultimately the way I see molecular data playing into this, I mean, I'm going to argue this afternoon that the problem with genomics is that we use it as a diagnostic test, whereas actually what it is the architecture of the healthcare record that you need going forward. And that if we flip the way, I mean, CYP2C19 is a great example. You're never going to order that test because it takes, whatever, a week, 3 days to come back. You've made all your therapeutic decisions before it comes back. If you have it in the record when the guy comes in with his ACS, you know before you've even done the angiography what you're going to do with the outcome. And so I think a lot of this is how we think about where the information is, how we begin to use it. And instead of letting it evolve in a haphazard way, we build a system to actually do it properly, a consensus-based system to do it properly.
Michael?
So I think my question will tie to what you were just saying. You talk about a lot of data offering very minimal value. And so how do you find the right balance as you construct your digital record between the data you will need for clinical care that's acutely usable and necessary and the data that you might want to have because for research uses down the line it will be of interest without overburdening the record to what we currently have?
So I think that's a very important question. So I think there are three pieces to unpack that. One is, and I know we're running out of time and have to be out of this room at exactly 1. One is exactly that, not disrupting current clinical care. So we built each of these as slivers, which will ultimately converge to be a single platform. That's the way we think about it. So you have to do something that works for an acute problem. So the problems, each of these was funded by an acute problem. So PCSK9 anxiety was what drove the lipid program, and same sort of thing for every other one. Blood pressure, we had to tag on to lipids because there's no funding for blood pressure. The second piece is asking, if you're thinking about the space that we occupy and you're saying, we have essentially almost everything we measure in medicine is largely in anatomy and physiology. So if you're saying, okay, how are we going to build out the rest of the unknown unknowns? This is something that actually we're working really hard to do in collaboration with Verily and the One Brave Idea, and with obviously Rob's help, thinking about how do you start to structure the dimensions that you're measuring in a way that adds real value, that's not overlapping. And I think that's going to require a concerted effort. I don't think we know the answer. We've thought of a variety of different ways of doing it. You know, there are endpoints that we know are important in homeostasis that we don't routinely measure. There are cellular functions that we don't routinely measure. You know, I told you about building a system for managing or measuring lipid macrophage function. You could imagine you could measure a lot of things in macrophages if you can get access to them, and maybe that ends up being a sort of dimensionality. We're doing X-ray spectroscopy to look at 113 elements instead of just the 13 routine things we measure. But in addition to that, you also have to think about the tools that are available, so things that are scalable. And then the final piece, which is how do you think about how you manage those data? Well, it turns out I think every other industry on the planet does a pretty good job of doing that. And a lot of it is thinking about creative ways of displaying the information. And that was one of the reasons we built our platform smart on fire so that you don't throw away any of the existing EHR, but B, you can build something that ideally, and this is how we've designed it, although it may not work as well as we think it will, has the patient and the advanced provider looking at the same basic data set, but at different levels of granularity. So for the patients, it's literally green, amber, red light. For the advanced clinicians, you can drill all the way down to raw sequence. And I think that's how we have to be able to think about it, is how do we build platforms that allow us to do the things that we want to be able to do, rather than things that digitize what we thought we needed to do in about 1860 or something along those times.
Great. Well, thanks again, Dr. Macrae, for an excellent presentation.
Thank you for your time.